Good evening, fellow Jays and friends. This is Mark Clapper, class of 1996 and Executive Director of College Engagement at Elizabethtown College. It is so nice to be with you this evening. Thank you for joining us. This is the first of our Etown Alumni Features series. And we are so excited. I am so excited personally about this evening because we are going to be featuring a very good friend of mine for multiple decades now, and just somebody who has been a really special part of my life, and member of the class of 2001. This is an individual who has been really engaged with Etown since he graduated. Pretty much literally since he graduated, he's been volunteering and involved with Etown as an alumnus. He has served on the Alumni Council. He's done numerous volunteer things for the college throughout the years. And he served on the board of trustees of the college and just really done many things to be supportive. He's spoken in classes as well. He's been a featured speaker by faculty members for years on different topics, and just somebody who has really done some exciting things, not just at Etown, but as you'll learn tonight, done some amazing things in as a professional. And he is a medical doctor, and he practices a very interesting and emerging field of medicine, and something that we're going to learn a lot more about tonight. And just couldn't be more excited to introduce all of you and welcome warmly Dr. Gurtej Singh, class of 2001. And welcome, Gurtej.
Thank you, Mark. Thank you so much for having me tonight.
Absolutely. This is great. I mean, as I mentioned earlier on, you and I have known each other for years, and I have absorbed some of the material just because I know you about physiatry. But what we're going to talk about tonight is a nice pull behind the curtain look at the profession, and then we'll learn about you as well. We'll learn about your story. We'll learn about your entrance into physiatry as a profession, and lots of other fun things too. I've got a couple things up my sleeve here that could be pretty cool later on. So really excited about this. But Gurtej, thank you so much for being part of this evening, and for just for sharing your wisdom, and you're sharing your story with our alumni and friends. So you have a presentation for us this evening, and so we are going to get started with that presentation. And Gurtej, at this point, take it away.
Well, Mark, I can't thank you enough. It's certainly very humbling, and it's a wonderful honor to be recognized, by Etown. Obviously, in volunteering, my time over the years, it just shows you how much Etown has always meant to me, and sort of set the groundwork for all of my successes year after year, and never forget. We should always never forget where we come from, and part of where I come from is Elizabethtown College. As director of college engagement, you've I think if there's anyone out there, watching us tonight, Mark Clapper bleeds both blue and gray at the same time. And I'm not sure how he does it. I really am not sure, but there's no one who loves Etown more than Mark. And thank you so much for this opportunity. And hopefully everyone will learn something new tonight. And hopefully those tricks up your sleeve aren't going to share too many of our old secrets. So.
You're just gonna have to wait and see, my brother.
Oh boy, here we go.
But thank you very much.
No, my pleasure.
And take it away.
Well, again, thank you everyone so much for your time this evening. As Mark alluded to, there is an opportunity as we go through this discussion that you're able to ask some questions of me. And what Mark and I will do is at the end of the presentation, go through your questions. So please don't be shy, don't hesitate. As my mom once taught me and continues to teach me, there's never a dumb question. So here we go, back to feeling spine. Let's see here. Let's get this going. There we go. As I sort of alluded to, you always want to remember where one comes from. Obviously, Etown being a large part of my education and my growth, but also in terms of volunteering back, a lot of growth as an adult and as a postgraduate. Learning things behind the scenes as a member of the board, to connecting with members of the community on a yearly basis. Obviously, very proud of having gone to Penn Charter. So any of Philly folks who are out there, that's my alma mater from home. And of course, medical school was Penn State, and a huge Nittany Lion fan, even though they're not doing well this year. As Mark sort of suggested, what is physiatry? This is a young field in medicine itself. It goes back to the late 1940s. It's essentially an offshoot of orthopedics, and what was sort of happening at that time was our veterans, and apropos, as yesterday was Veterans Day, so a big thank you to all of our veterans for their service to this great country. But veterans were coming back from World War II, and medicine at that time was sophisticated enough to help keep people alive. But there was a big lack and a big gap in how do we help patients with their function, right? So medicine over the years has allowed us to increase the quantity of our life. But how do we enhance the quality of our life? How do we make each day better for ourselves? How can we, as I sort of, say to my patients, keep, we're always 19 up here, but, back down in the spine, that keeps growing each year after year. So how do we keep our spine? How do we keep our joints? How do we keep our body 19? And keeping up with what we want to do and what our brain wants us to do. So physiatry helps to combine a bunch of fields in medicine, orthopedics, neurosurgery, neurology, rheumatology, and medicine, and focuses on the quality. How do we enhance joint range of motion, strength? How do we help people recover from an amputee or from an amputation? And over the 70 years, physiatry has expanded and is continuing to expand. Here's just a fairly comprehensive list. I may have missed, one or two of the subspecialties within physiatry. So, as some of you may be familiar, you see your internal medicine or your internist on a yearly basis, but then there are subspecialty fields within medicine like cardiology and pulmonology and gastroenterology. Well, similarly, physiatry has a number of different subspecialties. And so I've listed a lot of them here for you. What I sort of have specialized in and has become a real love of mine are the bottom four here on the right side. So combination of sports medicine, pain medicine, interventional spine, and regenerative medicine. Figured I'd give you a little bit of a background so that you know my current state of professional life. I am board certified by the American Academy of Physical Medicine and Rehabilitation, both in its primary boarding as well as its subspecialty boarding of pain medicine. And then a few years back, took a few months to do a board certification in stem cell and regenerative medicine. I've been very fortunate and blessed to become a partner and director of the Interventional Spine and Pain Program at the Orthopedic Associates of Central Maryland in the suburbs of Baltimore, and have enjoyed teaching residents and fellows, young attendings, young doctors in this field and in the various procedures that we do and perform around the spine. And of course, been an invited lecturer to a few of the local institutions. Before we get too deep into what is physiatry and my passion, what is spine, I do want to make sure that, tonight everybody understands I'm not able to give each individual some personal medical care. However, I am here in the Baltimore area, and if you're close, I'd love to see you and be able to provide that for you here in the office. And that the content that I'm providing you tonight is really just strictly informative, educational, not going to get too detail oriented, but that it is mine and mine alone. All right, so with that, how do we get to the basics of spine? And so, the spine is made up of essentially 4 different sections, and I've listed them here on the left. And so you have your neck, which we call our cervical spine, the mid back, the low back. The sacrum is sort of the back of your pelvis. It's kind of the spot in between your butt cheeks. And then, of course, the coccyx, which is all the way at the very, very bottom, and that is also, we call that your tailbone. At all of these different levels, we have bones, discs, joints, nerves. And so I've sort of provided here just a couple illustrations to help show you what a normal MRI may look like, and then a caricature here. And then you can see in this center, or the diagram on the left, you have a bone, there's a disc in the middle, and then a bone on the bottom. In the back, you have where the spinal cord runs, and then this yellow guy that's trying to peek its way out, that's one of the nerve roots. And so when patients get nerve pain down the arm or leg, it's this structure right here that tends to get injured or irritated. And a lot of times it's either some arthritis that's happening at these facet joints, which are the joints at the back of our spine, or it's this disc which degenerates or herniates itself and irritates the nerve. And then on the far right, you sort of have the MRI, which everybody loves to talk about. But you have the spinal cord that sort of runs in the middle and becomes this white stuff here. And then, of course, in the front of the spine, you have the bones and the discs. I thought it'd be kind of interesting to show some more pictures first. Here on the left, you have an X-ray. These are 2 different views of the X-ray, and they kind of help us understand the basics of your spine and making sure, are there any fractures or a misalignment? Kind of gives us the basics to get a patient started on the correct treatment plan. It does not tell us everything. It's difficult for us to see the discs very well. You can't see the nerves at all. So it's a preliminary picture that helps us when we take care of patients. On the right, though, you'll see what is called a CT scan. It used to be called a CAT scan. These help us show really good bone anatomy. So when we're concerned about things like a fracture or we're concerned of a misalignment, CT scans really help us the most. And everybody thinks, oh, the MRI is the most important thing. Well, not always, and in not all situations. Here you can see the fractured bone in the middle, near the top, and we call that a biconcave. It's sort of fractured on the top and fractured on the bottom. And then you have 2 normal bones, right? And then here at the bottom, we have both a degenerating disc, and that's this darkening portion here in between the bones, and you also have a misalignment. So the back of this bottom bone doesn't really line up very well. And so that can also cause nerve pain and injury to the spinal cord. Some more images. Here's another CT scan, and you can sort of see how the facet joints, which are the joints in the back of our spine, undergo arthritis. And unfortunately, it happens to all of us. So no one out there be surprised when one day your physician tells you that you have arthritis. Happens to everybody. The question is, when does it become painful? And then when it does, how can we help manage that pain? On the right, I selected a few images that have a cancer inside of the bone. This is one of my other areas of expertise, which is treating spinal fractures specifically that have come from a cancer source. And I'll get into that later in the presentation. There's a procedure I'll talk about, but this is kind of what it looks like on the CT scan. You kind of have all this normal bone, and then all of a sudden you have this big hollow circle here in the middle. And then an even more dramatic example is here on the bottom. You see this letter A, and you can see this in the back. There should be a nice circle of bone, and on this right side, it's all eaten away, by that cancer. While I am an interventional spine specialist and I try to help all of my patients without having them to undergo major spinal surgery, I did want to sort of point out that of these two pictures, the top two are something that I could treat with the patient, not having them undergo major spinal surgery, whereas the bottom two, unfortunately, the extent of that cancer mass has just eaten away through the bone that this patient would have to go and see a spinal surgeon to get treated. On the far left, we have two images of a normal MRI. Like I said earlier, everyone is so excited about MRIs, and I'll tell you the honest truth there is it's just one piece of data. The X-ray, the physical exam, the questions that I ask my patients, and the answers that they provide me about how their pain is and why their pain is actually way more important than the MRI. But here on the left, you can see a normal one, and it's got the spinal cord here in the back, and it's got these bones and beautiful discs in the front. And here on the bottom left, in the center circle here, this is where the spinal cord lives, and all these little dots are your spinal nerves, and they're going to end up, going down your leg and allowing you the power and the sensation in your leg to walk. And then on the far right is a big giant disc herniation. So this big blob that spits back out into the spinal canal is pushing up on a nerve. And then the bottom right image, it's pushing out to the left more than it is on the right. I would expect that this patient comes in and says, hey, Dr. Singh, I've got a pain that runs all the way down my left leg. But I have been surprised, and that's why it's not the end all be all, is because sometimes a patient like this will tell me they have very little pain. Or sometimes a patient with this MRI has come and told me that all their pain's on the right side. And while that's puzzling, that's why it's so important to know that your story, when you go see a physiatrist and you tell them what's wrong, the more detailed you are about exactly where the pain is and where it goes, will help guide you into the best treatment that we can offer. And like I said, why is it so important? At the end of the day, we're really just trying to figure out that we understand what's going on. We're trying to make sure that we're not missing something critical, right? So unfortunately, like a mass or what we may consider as a tumor. But the one piece of information, and there are going to be many I hope that you take home with you tonight, but the one big piece is this last line here. What imaging does not do, and it does not tell us where your pain is or what your pain feels like. And so that's really the crux of that great sort of physician-patient relationship, is where the physician and the patient are asking each other questions and answers to help pinpoint what's bugging them, and then we just use the MRI later on to confirm that. So I did want to then jump into a couple slides of conditions that we'll see and that you may experience over the years. And then I have two more slides at the end that are going to talk about some of the procedures and some of the cutting edge things that are coming. So in terms of spine conditions, one of the very common things I see is what's called musculoskeletal, that's MSK, or facet-mediated pain. Probably, patients in their late 40s into their 60s and 70s, they'll come in, they'll give me the descriptions in that top line. If for the older folks in the audience tonight, you may remember WD-40. A patient with facet pain comes in and says, hey, doc, you got some of that WD-40? I just need to loosen up my back a little bit. And That's really a telltale sign. When I hear that and a patient describes that to me, I'm thinking, okay, this patient probably has facet-mediated pain. Let me make sure they don't have anything else going on, and then we can do things to help treat their facet pain. Another very common thing is what people in the community call sciatica. My patients know that I never use that phrase or term. It's not really an accurate term that's used in the community. Sciatica really is what I've listed there for you. It is a numb, tingling, burning, electrical, pins and needles, almost like a fire at times. And it will either start, in the back of the shoulder and go down into your fingertips, or it'll start in the buttocks and go down towards your toes. A lot of patients come in and, they say, oh, my hip hurts. But when they point to their hip, they actually point to their buttocks. And I encourage everyone, if you ever are in this situation and need to talk to a physiatrist or even your internist, if it's hurting you in the back or in the buttocks, don't use the word hip, and don't use that phrase. It may be more polite to say hip, but unfortunately, I've seen far too many times patients that have had hip X-rays, pelvis X-rays, hip MRI, have gone and seen the hip orthopedic surgeon, and they end up in my office frustrated because, quote, nobody knows what's going on. And the first thing I said is, okay, show me where your pain is. And the first thing they do is they point to their buttocks. And, that's exactly what it is that patients politely say hip, and really, in fact, it's their low back and their buttocks, and they go down the wrong path. So it's okay to use those words with us. We're physicians. I trust you. We've heard everything and every story under the sun. So no need to be polite. Tell us that your butt hurts. I promise you, it'll get you to an answer and a treatment solution much faster. So, and then finally, discogenic pain. This is also pretty classic. It's dead center. It's not right or left. And when patients bend forward or lift something heavy, it typically causes a very stabbing-like sensation, dead center in the back. A couple other conditions that are unfortunately becoming a little bit more popular these days. There's something called cervicalgia or neck pain. This is like the facet pain that I talked about in the previous slide. If you can see my mouse and pointer, it's these joints here in the back. This is the front of the spine, and then you have these pointy bones that stick out towards the back of the spine. And sort of in the middle back portion are these what are called zygapophyseal joints. It's a fancy word, but really it's your facet joint, and it's what actually undergoes some arthritis, and that's where you get this sort of neck pain that can radiate towards your shoulder or shoulder blade. When it involves the upper portions of the neck, it can cause a headache, and the headache will go up the back of your head. Some people will hear the phrase occipital neuralgia, and essentially it's an irritation of the occipital nerve as it comes out of the spine and travels up the back of your head. When patients have an injury or whiplash, especially specifically a whiplash injury, so a rear end motor vehicle collision, or falling and hitting their head, causing it to jerk back very quickly, they can also get this cervicogenic headache or occipital neuralgia. This is something that's unfortunately becoming more common because we don't use our necks very well, but can be treated and managed fairly easily. And then, of course, the last one, text neck. I think that's pretty easy. Everyone has a cell phone these days, and everybody, if you check yourself, you'll find that you are bending your head forward, to check your texts and to play on your cell phone. When I first started and cell phones were not all that popular, neck pain really wasn't a majority condition that I took care of. I took a lot of back pain and pinched nerves. Nowadays, I see a lot more neck pain. And for those of you who even have, teens and young adult children, don't hesitate to correct them and to sort of correct their posture. It's sad though. I see a lot of, 14, 16, 18-year-olds. And when I walk in the room, they're slouched forward, their shoulders are rolled forward, and they're on their cell phone ticking away. And I look at the parent and I say, is this what they look like all day long? And the parent goes, yeah, that's what they look like. I said, well, there's your pain. Thanks. You can pay your bill on the way out. And so essentially, it's a lot of text neck is just posture management, right? Roll your shoulders back, put your head up into the sky, get your chest out, put your neck in the position that it's supposed to be in, and you'll take care of that condition fairly quickly. So as promised, I did want to kind of touch base on a few procedures and a few surgeries that I perform, kind of become my passion as I have navigated my way through my medical career. A lot of pain docs, you may know, they do a lot of spine injections or cortisone injections. And I've listed a few here, including the facet blocks and the radio frequency ablation. What I kind of want to, one piece of education I'd love to get out there is, when we do these injections, we're not curing what's going on. We're helping you to manage your symptoms. We're trying to decrease the pain so that you can actually rehabilitate correctly, right? So, we're using pain management to get back to the fundamentals of physiatry, which is rehabilitation and adding quality to the quantity of the days that you have here. A lot of people, unfortunately, think of our injections as sort of a magic bullet or the quote quick fix, but there's nothing fixed. You'll still have that arthritis. You'll still have the degeneration in that disc. The purpose there is to decrease your pain so that you can improve your posture, so that you can strengthen your core, strengthen your back, get into physical therapy and have physical therapy be successful so that you learn all of those home exercises that you're supposed to do every day. I joke with my patients and I tell them, did you go to physical therapy? Oh, yes, doc, I went twice a week for 8 to 12 weeks. Oh, that's fantastic. Well, did you do the home exercises they taught you? Well, doc, no, not all the time. And then my joke comes in and I say, so when your kids go to school, you never make them do their homework, right? And then they kind of get it. Like, this is life's homework. Keeping good posture and strengthening your core, and it's an everyday thing, and that's what helps in the long run. So one other there, you see the third one down, it's called a kyphoplasty, and then the picture here on the upper right is a sketch of what a kyphoplasty is. And essentially, this is a scenario typically seen in elderly patients. They'll have fallen. Is usually the number one reason that they fracture a bone in their spine. And if you remember the CT scan from a little earlier that showed the fracture, this would be that would be the type of patient that we would do a kyphoplasty on. The literature and the data, it's overwhelmingly positive. Patients who have a spine fracture, who have severe 8, 9, 10 out of 10 pain, difficulty getting out of bed, difficulty rolling over. These patients do dramatically better when we are able to quickly get them in and pour some cement into their bone. It's a procedure that is done as an outpatient. There's actually no cutting involved. It's really 2 needles that we place from the back of your skin through the bone into the front of the spinal bone. Patients go home after about 45 to 60 minutes of recovery. The procedure can take anywhere from 30 to 60 minutes, just depends on if we're doing 1 level, 2 levels, or if it's a very complex fracture that requires a lot of extra accuracy. And what ends up happening is we use X-ray guidance to show us as the needles are passing through the bone and into the fracture that we're doing that accurately. And what we try to do is open up a balloon. And the balloon helps to create a reservoir for where the cement is going to end up. And by doing that, we increase the safety of this procedure. And so we know now that, we open up this balloon, we it's what we call reduce the fracture, or sort of pop that bone back up into its normal position. And then when we collapse and remove the balloon, and we can do that through the needle, we then mix a cement that we then inject very slowly into the cavity that the balloon created. And when patients say, well, what do you mean a cement? I say, well, have you been to Lowe's recently and have you ever mixed cement? That's what the operating room smells like. Then they, of course, ask me, well, how long does the cement work, or how long does the cement last? And I tell them, don't worry, it'll outlast you. And so the beauty of the procedure is that within about 48 hours, the majority of patients are about 85% pain improved. And if you can think of, that 70 or 80-year-old patient who, can't spend, 2 weeks laying in bed because of pain, it makes it very easy to select this procedure for your loved one. If you remember also back, I talked about cancer as being a source of one of the fractures to your spine. So when we do that procedure, and I'm sorry I don't have a caricature for that, but before we put the balloon in, so we put those introductory needles in, we can actually insert a radio frequency probe. So it's a probe that actually heats up, and it heats up to 80 degrees Celsius and kind of almost chars, and what I tell patients, kind of cooks the cancer on the inside. Now, again, it doesn't cure the patient of cancer, but it helps to destroy how big that cancer is inside the bone. And then after that's done, we fill it in with cement, and patients do really well, and they can continue their cancer therapy with a lot less pain. At the very bottom, there's something called a spinal cord stimulator. It's also one of my expertise. It's what I educate other physicians on nationally, teaching them who the right patients are and how to place the device safely. I kind of educate my patients to tell them it's kind of like a pacemaker. When your heart doesn't beat normal, you put 2 wires in a small battery, and those 2 wires help your heart beat normally. With a spinal cord stimulator, you have patients who have had spine surgery, multiple spine surgeries, pinched nerves, trauma to their legs or to their arms. And that constant nerve pain is something that they have great difficulty getting under control. And so a spinal cord stimulator can help to control that pain for patients. And then we don't have to give them so much pain medication because of that. And in terms of my presentation, this will really be the last major slide. These are 3 relatively new procedures. They are designed for patients that have what it's called spinal stenosis, or as other people call it, neurogenic claudication. And essentially what we're trying to do for patients, again, without having them undergo a major open spinal surgery where they may get what people know as rods and screws, we're able to help patients by decompressing. And what we mean by decompress, we mean actually physically remove the overgrowing tissues. So whether that's the overgrowing ligament, whether that's an overgrowing facet joint and arthritis, the 2 procedures at the top are done again as outpatients. Patients go home the same day. Procedures can take anywhere from 30 minutes to 2 hours. All depends on how aggressive we have to be or how many levels we're doing. And again, the data shows that for more than 5 years after these procedures, patients are able to enhance the quality of their life. So, when you think of that 70 or 80-year-old patient who has other medical issues and can't undergo spine surgery, These are procedures now that can help them really live more meaningful lives, and let them go watch their grandkids play soccer, or make it from their apartment down to the meeting hall, if they're if they're in an assisted living facility. The last one, endoscopic decompression. This one I am super geeked by. If you have ever had a knee problem, and an orthopedic surgeon says, well, hey, let's just go scope your knee and clean stuff out. Endoscopic decompression of the spine is that procedure for the spine. It's starting to gain traction, has been done in Europe for a number of years, but it really will allow patients to get a disc herniation removed with an incision that's not even the size of your thumbnail. So I'm very fortunate. There are some mentors out here in Maryland that have been kind to help me learn this procedure and really sort of grow and become more of that interventional spine surgeon, and helping patients not get that big giant incision in the back. So hopefully I didn't whip through all of that too fast. Hope that I was able to give all of you a little idea and get a sense of my passion for what I do in treating all forms of pain, as well as spine pain. I did promise Mark that I would find some old pictures and we'd throw them up here at the end. Obviously, playing tennis at Etown was very important to me. And that's how Mark and I really first met. Spent a lot of time with Student Senate, and share a few pictures from different Student Senate activities. And one of my good buddy Greg has been a great friend to me all these years. I apologize. I have no idea that was those ties were fashionable apparently back in the late 90s, but they're not fashionable now. So I'm sure that Greg ties a better tie these days. Hopefully everyone has a bunch of questions. I'm going to kind of stop sharing the screen now and see. Bring Mark back on.
Gurtej, thank you so much.
Oh,
that was awesome. That was fantastic. I feel like I have my eyes opened here. And actually, we did get a question. We got a question, and it is about. Will you talk about stem cells / PPRP?
Sure. So stem cells and regenerative medicine is actually very, very new as a field. I would first start by cautioning patients. We don't have the data to give definitive answers when it comes to stem cell injections as well as PRP. Simply put, PRP stands for platelet-rich plasma. And so if you remember your days back in biology and chemistry, you draw blood, from your vein typically in the arm, and we put it in a centrifuge, and we centrifuge that twice to be able to get the red blood cells. Those are the heavy things in the blood. They fall to the bottom. And then the water component of our blood kind of rises to the top. And the thin layer that's in the middle is called the platelet-rich plasma. And we're still understanding all of the different components that are in the platelet layer. Obviously, there are a lot of platelets that are in there. There are a lot of different nutrients, chemokines, cytokines, and other sort of nutrient growth factors. And it's those growth factors that we believe help to stimulate healing where we then re-inject it. So a lot of patients will get, a PRP injection, whether it's in their knee joint for knee arthritis, or in their elbow for tennis elbow or golfer's elbow. I've done a few into the spine, whether it was in the facet joint, whether it was in the disc, or whether it was on the nerve. The problem is, at this stage of the game, very few, if any, insurances cover the procedure. So a lot of patients are going to be paying cash for this. Well, if a patient comes to me and says, I'm going to pay cash, can you tell me that it's going to work? There's very little data that says it works. What's out there is a lot of case reports, right? And so I would educate everyone to say there's a difference between data and there's a difference between case reports. Case reports are, hey, I have these 5 patients and I injected them into their knee and they did great. So I'm going to put that together in a paper and I'm going to publish it in a journal. I'm not going to tell you about the 10 people that I injected who didn't do well. And so that's the difference between case reports and data. Data is you collect, the next 10, 20, 100 patients, and you accurately report what happens to all of them. And because insurance companies are not involved to pay it, there's very little motivation for a lot of the companies that are out there that sell the centrifuge units. There's no motivation for them to do high quality, high end data. When it comes to stem cells, now that's a different product, right? So that's something that we can harvest from the hip bones in your back, or we can actually harvest from your fat tissue. And of course, when you tell that, a lot of people perk up. They said, great, you're going to give me a liposuction. This is awesome, right? I get a liposuction and I get a stem cell. This is perfect. But again, the problem there is that the FDA has been very strict on how you can get stem cells from the fat tissue. And when it comes to the bone marrow stem cells, as patients turn 35, 45, and 50, the concentration and the viability or the survival rate of those stem cells, they go down quite a bit. So I've had patients come to me, they're in their 60s, they're in their 70s, and maybe they have some diabetes or maybe they were a smoker and they say, okay, doc, I want a stem cell injection for my bone marrow. I tell them that it's not going to be worth the price because the amount of the quality of that stem cell just isn't there as you get older. A lot of patients will then turn to things like amniotic fluid or what's called amniotic stem cells. And I very, very much caution patients to understand that, the price you're going to pay for an amniotic procedure and the guarantee that you're going to get a success rate is probably no better than a cheaper cost like a PRP injection. So it's absolutely an emerging field, and caution really should be the guidance that patients understand that when people are just marketing, hey, let me just inject you with this fluid, there's no actual data, and they may argue to say that there is. What they're telling you is that they're case reports. They're not telling you there's actual high-end data.
There's a big difference between those things.
Yeah, very much so.
Yeah.
So, and that's an easy comparison to say, I have a lot of high-end data that shows kyphoplasty for a spine fracture works. And there's a lot of high-end data that says, when your knee goes bad, you get a total knee replacement and you do well. That's high-end data. Those aren't case reports. It's been proven year after year. Hopefully we'll get there with stem cells, and hopefully we'll get there with PRP. And there's a lot of push for that, but there's no good quality motivation for it yet.
Yeah. Oh, that's helpful. Yeah, that's great. Great answer, Gurtej. We actually have another question too. How does your work intersect or not with chiropractic work, which also deals with the spine?
Sure. So I wouldn't say that I see, there is an overlap to a degree. A lot of patients that I end up seeing tend to come to me after having seen a chiropractor. And from that perspective, I would say I'm a little biased, right? When a patient comes and I say, so what have you done? Oh, I went to the chiropractor. Well, did it help? Well, no, it didn't. So unfortunately, nobody's going to come to me if the chiropractor helps them. So I'm a little biased, and that's fair. And I get that out there to patients. My objective and the way I go about treating patients is I want to empower my patient to take care of themselves, right? I saw a 21-year-old gal earlier today, and she had normal x-rays. She had normal x-rays 5 years ago that she brought for me to review. She had no pain down the legs. she's deconditioned. And we talked about her doing a really good home exercise program. And while I didn't tell her this, but my hope is that I never see her again, right? My hope is that she understands how important the home exercise program is. She's able to incorporate that into her daily life going forward, and she takes care of her spine. A lot of patients come to me and they say, well, the chiropractor wants me to be seen 2 to 3 times every week. Yeah, from a professional perspective, that may be what works for them. My goal is to try to empower my patients. How do I help you take care of yourself? And I'm always here for you. So there's some intersection, not a lot. And especially nowadays, as I move further and further into the surgical world, doing these sort of highly advanced procedures like the interspinous devices and the endoscopic decompressions, it'll probably be even less. But on the true physiatrist, as I sort of say, and my dad's a physiatrist, and I don't know if Mark, I know you know that, the audience probably doesn't, but my dad's more of a true physiatrist. He did EMG and nerve conduction studies, and he saw stroke patients, and he saw patients with knee pain and shoulder pain, and he really did the whole spectrum of what physiatry is meant to be. I have found this wonderful little tiny niche up here in the corner, and I get lost into being more of a interventional spine surgeon. But the true physiatrist would interact far more with the chiropractor in terms of patients going back and forth.
Well, that makes sense. Yeah. So that's actually a really interesting point, Gurtej. So would you say that that's, because I was going to ask you, how did you find your way into physiatry? But was it through your father's work that you kind of, saw this as a potential pathway, or was there some other kind of light bulb moment, or somebody that kind of had an influence on you to help you kind of move in that direction?
No, there's no question that my family, whether it's my parents, my grandfather, they definitely had a huge role of influence. It's when you're a kid and that's what you see growing up. It's just what you become comfortable with. My mom always tells a story about me being 3 years old and driving around the driveway in my tricycle with my dad's briefcase, and she said, "Where are you going?" I'm going to the office. It's what I knew. Funny enough, though, if you had asked me the same question back in the beginning of medical school, I would have told you, I'm going to be the Philadelphia Eagles team doctor. I'm going to be an orthopedic surgeon. I'm going to be the Eagles team doctor. That was, what I was set to do. And lots of fun twists and turns, through medical school, learned more about, what it means to be a team physician at the NFL level. And it's not as much medicine as you think. It's a lot of management of players and management of, high contract individuals, getting them back on the field. And to me, that's not medicine. And, just having the influences, of my parents and my grandfather, that's not what they, did or what they showed me how to do. So being able to go into physiatry, and initially, went down the sports medicine pathway and was thinking, yeah, I'll be a sports specialist. And during my training, I actually was the team doc for a local high school football team up in Michigan. And that was great. That was a lot of fun. And that really was more true sports medicine, right? You're not really managing a contract for a high school player. You just, you want their safety out there first and making sure they're not injured to get back out and play healthy. I dabbled in that a little bit during residency. And then, when I found pain and spine, I've just, it was the path for me.
Yeah. Well, I have to say too, Gurtej, that, something that has really stood out to me throughout the years of knowing you and kind of, just being along, as a voyeur, so to speak, in some respects, as to how your career has developed, and you've kind of centered into this part of your medicine practice. I have to say that it really feels like you are so aligned with kind of what you or what it appears your life calling is. Like it really feels like this type of medicine, this type of work lights you up, and it really, it doesn't feel like at least from my perspective, it doesn't feel like work for you. You know, it feels like it's something that is kind of your, for lack of a better word, calling. You know, is that how you would describe it?
I think that's fair. And when people ask, how did I get here? Um, at the end of the day, there's a divine power in all of our lives. I certainly believe that myself. You know, I've succeeded at a lot of tests. I've failed a few tests. Succeeded at things in life, failed at a few things in life, and yet all along, you just continue to have faith that that higher power is steering you. A lot of times you don't know why you're being steered, but the strength in that faith allows you to just sort of blindly follow along. You're right. I can't be more blessed or thankful for what I do. Sure, maybe I became a physician and went into a different field. I may not be as passionate as I am in this. Sometimes I actually kind of catch myself like, okay, man, turn your brain off. Like, like stop thinking, let's turn on some sports or put on some music and get your
Sure.
brain, because the interesting part about spine, and I guess the reason that I have enjoyed it so much, is that there's no one right answer,
Mm-hmm.
right? So, if you are a Caucasian female in her 70s, or if you're an Indian male in his 60s, or if you're an African American, in your 30s, and each of those three people show up to an emergency room with chest pain, there are three different protocols that the ER physicians and the cardiologists will go through. And a Caucasian cardiac system, an Indian cardiac system, an African American cardiac system actually get treated differently because the science and the algorithms are so well played.
Mm-hmm.
When it comes to pain, my 8 out of 10 and your 8 out of 10 are totally different things.
Yeah. Yeah.
And I've had patients, they come in and they look miserable, and you ask them their pain score and they tell you 4.
Hmm.
I'm thinking, really? I'm sitting here right now. I played tennis last night and my back's a 4. What is this? And right. So it's
Yeah.
and so from that perspective, because the subjectivity of pain is so different, and as I pointed out in my presentation, the MRI and the X-ray don't tell me your pain.
Yeah.
Everybody gets their own treatment plan. I kind of consider what I do as very much being out in the wild, wild west. I mean, I guess if I could have been born at a different time, I probably would have picked 1800s California. Go do what I want to do. But it's allowed me, to sort of play in this box and not necessarily be confined that, oh, here comes another, Caucasian female with a heart attack. Guess I got to do the same thing over again.
Yeah.
And so from that perspective, it definitely it keeps my brain juiced all day long. And that's definitely one of the aspects of physiatry where we're still writing a lot of the rules because it's such a young field. And so you can treat patients and tailor patients and their treatments individually, and patients really appreciate that.
Yeah, yeah, absolutely. And I think too, it feels, just from hearing you describe this and kind of hearing you describe your work, that this type of medicine really aligns with a personal ethic that you have, moral calling as well as a doctor. Um, you know, is that's my perception. Do you feel that's true as well, that this particular slice of medicine aligns very comfortably with that part of you as well?
No, there's no question. I mean, I would certainly hope that all physicians hold themselves to the highest of standards, both ethically and professionally. Yeah, a lot of life these days becomes economics,
Yeah.
and it's about making the dollar at the end of the day. Um, but you have someone's life in your hands.
Yeah.
And again, sort of um, throughout the years and my formidable years, right? I've got parents who are very sort of faith-based and very religious and spiritual and in Sikhism. I attended the William Penn Charter School, which is a Quaker institution, and for many years participated in a meeting for worship, not necessarily a religious service, but still nonetheless a spiritually driven service. And then, of course, the Brethren heritage, at Etown, right? So faith, not necessarily the Sikh faith, in my academic and pursuits, but faith in general has really sort of been a large part of my upbringing, through my early 20s. Can't say Penn State's a faith-based institution, but prior to that, yeah, those sort of things, and understanding how, at the end of the day, we all just want to help each other, right? We are trying to be genuine and unique. We're trying to understand who our brother and sisters are, and using, some professional knowledge that I have, I can help, these brothers and sisters, in their journey.
Sure. Yeah. And I think that's a really great point that you bring up, that going to a, Quaker school and then coming to Etown, there are very similar historical characteristics and values between Quakers and Church of the Brethren, Mennonites, and so on. And I think specifically for Etown, we have such a special motto at the college: educate for service, and
Yeah.
it's something that is so applicable. It's something that current students know. It's something that lives on in our lives as alumni. How do you see educate for service playing out in your daily life as a professional, as on your personal side, that kind of thing? Do you see that kind of inspiring you or cropping up in different ways?
It's hard to say that it crops up, only because I think it's completely interwoven,
Yeah.
right?
Well said.
So from that perspective, it's completely interwoven, right? I mean, you in tying not just educate for service, right, but in the Sikh faith, service, and what we sort of, the Punjabi word is seva, seva, right? So seva is selfless service, right? So almost my entire life, and whether it's an influence of my religion, whether it's an influence of Quaker values, whether it's an influence of the Brethren values, serving others is what community is about. Serving others is what the religious community teaches us at its core, that together we are one. And sure, we may call ourselves Sikh, or we may call ourselves Brethren, we may call ourselves Quakers, but really we're still all one. There's you can't make two out of one. We're all one. And so, yes, the educate for service and doing service projects was something that my parents encouraged me very much to do as a kid. And so whether it was serving meals at our local Gurdwara, which is Gurdwara is the word for the Sikh temple. So whether it was serving meals at our local Gurdwara on Sundays, whether it was service projects in high school, and then the opportunity to continue those service projects while at Etown, it doesn't crop up anymore. It's fully interwoven into what I do. And so nowadays, and I don't know if I'm cheesy in this way, but I use my education to serve my patients, because at the end of the day, a lot of the back is still being figured out. So educating patients is probably what I spend half my time doing.
Oh, that's great. Yeah, no, I think that's awesome. You're empowering them to make decisions and to have a role in their own health and well-being, based on what you know about their condition and medicine overall. So I think that's awesome. And and when I think about Etown, I know each of us has our own Etown stories, and or Etown story, I should say. And I know from talking with you that there's some people who really have made a big difference in your life. And I think of people like Dr. Jim Dively, and I think of you mentioned also Dr. Jane Cavender and Dr. Tom Hagen, and even somebody who I credit in my own Etown experience as an English major, literature major at Etown, Dr. Lewis Martin. was one of my, transformative, faculty members for me too. But you have some really special people on the faculty side. Were there other people in your Etown career that you can really point to, like those that I just mentioned, that really made an impact on your life in a special way?
Yeah, I mean, obviously, serving with, well, clearly as a bio major, I spent a lot of time in class, right? So, those professors that you mentioned, should be really credited with a lot of my success, because it's, their guidance, their education, their kicking my behind when I needed it. That really, that's why I'm here today, right? No question about it. Others outside of the faculty realm, well, certainly the dean of college life played a big role, because I was in student senate so much.
Yeah.
And then of course playing 4 years of college tennis, right?
Yeah.
So Kathy was our head coach, and then John Flood, was my coach as well. A lot of people remember Skip Roderick, right? He was our assistant coach, which everybody gets so confused. They're like, "How do you know Skip? You weren't a soccer player." And I'm like, "No, but he ran my tail when I was a tennis player." So,
Yeah,
you
yeah.
know, and as is actually, here's a funny story. So, about I want to say 2015, somewhere in that range, 2015, I think I was at a conference in Montreal. There was an international neuromodulation conference. So, when I talked in my slide earlier about spinal cord stimulators, one of the major international conferences is the International Neuromodulation Society. So I was up in Montreal and, went for that conference, and I run into this gentleman who actually is an Etown grad and played under Skip. And so we got to, it was great. We got to talking and, sharing some crazy Skip stories as they can all get. And of course, he says to me, "So what was your nickname?" And, Skip had nicknames for all of us. So it was great. We got to share each other's, Skip nickname for each other. And, I ended up working with him through another device company. He was working for a device company at the time.
Sure.
So we got to collaborate on a few projects together, and, the Etown connection. And then if you want to hear the craziest part about that story, just before the pandemic, I was going to start a new procedure to help patients with chronic pain.
Mm-hmm.
And his son shows up as the rep for the company. I'm like,
No way.
no, I was like, you have a really distinctive last name. Do you happen to have a dad, that went to
Yeah.
Etown College? And he's like, "How do you know Etown College?" I'm like, "Oh, call your dad. He'll tell you the whole story." So Etown still props up, and actually what's really nice is, here at our practice, we have pamphlets that kind of, give our little bio and, what our fields of interest are. And of course, Etown is listed, as a proud 2001 grad. And I've had a few patients that say, "Oh, my cousin's daughter went there," or, "Oh, my, grandchild goes to Etown." So fortunately, being, only 100 miles away or so, Etown still pops into my day-to-day world.
Yeah, no
Yeah.
doubt. Well,
Yeah.
I had it queued up as something that I was gonna do. I told you I have a couple of maybe surprises that I can share with you. Um, I'm I think about so I ask you about leading into this your memories, your favorite
Mhm.
memories and things like that, and I have a couple of
Okay.
favorite memories for you. So maybe that one. Where that's a picture of Gurtej right in the middle, and then really awesome guy. We both love him a lot. John Flood
Yeah.
on the one side as head coach, and then I'm on the other side as assistant coach. And then I can't help but take your team picture in that moment, your individual headshot. Got to get some action shots in here too.
Hey, there you go.
Serving, got to
Oh,
get that going.
thank
Maybe one
you.
where you're kind of using that trademark forehand of yours. And then of course your senior year, got to get the new headshot in there too. So,
you.
those are some favorite memories, of mine. But I think, just as a way of wrapping up, Gurtej, what lingers with you? You've served as a board of trustees member, which is, you are in the core leadership group, and you were in that leadership group for a number of years, and you've served alongside some really really fantastic people, alumni and others who weren't alumni but love Etown so much. What was that like for you as a board member, serving at that level?
It's certainly it was a huge honor. You hear about the board of trustees, and even as a student, as much as I was involved with student senate, you go to student senate meetings, and then the president of student senate would come back and say, "Oh, so we met with the board of trustees, met this weekend," and they give you an update, and be like, "Who are these magical people that sit in this magical room, and what do they do?" And it was very much an honor to get a call from Dr. Long, in his last year as president, to consider me as a distinguished alum to serve. And he drove down. We had dinner together, and it was funny because I knew right away what the answer was when he asked me. But I said, okay, you know what, Dr. Long, let me reach out to a few current board members. Let me understand what it's really going to take and what it's really going to mean. And do I have that time, and do I have that expertise? And, of course, as a young, I think it was like in my early 30s at the time, I kind of questioned, in the sense of, why am I being selected at this age, right? I mean, I'm just out of fellowship training. I've never run a company. I've never managed financial accounts. And it was very interesting how the academic side of the board of trustees really it was a calling for me. And so serving on the academic affairs and cultural affairs committees, the marketing committee, really the fact that our board, made up of approximately 40 members, incorporates every single year incorporates at least 2 young alums. So individuals who are 15 years out or less, really helped to keep the other board members, a little better pulsed with, what's going on campus, or what were issues that were more contemporary compared to when, a 1960s or 1970s Blue Jay alum would have remembered. And so to have that experience really definitely transformed, my career. It allowed me to be a board member for another local organization here in the Baltimore area, which I served for 2 years. And the givings that Etown has given me, not just in education. I mean, coming to Etown, was to go on to medical school, right? There was a very defined purpose there.
Yeah.
But then Etown gave me the opportunity to play, Division III tennis. It gave me the opportunity to enhance some of my leadership skills, and make mistakes in enhancing my leadership skills, in student senate and other activities. But then to also give me some board level experience, Etown just kept giving back. And so serving on different committees, coming back to campus. Hopefully, Mark, you get us back to campus soon.
I hope so.
Yeah. But,
That's the plan.
but getting back to campus, I hope always to keep giving back, and then certainly encourage all my other Blue Jay members. You can give back in so many different ways, and I encourage you to do so. Etown will give it back to you going forward.
Yeah, 100%. Well, and I think, it's something that I'd be remiss if I didn't share this, but we had a comment come in from our from the chat, and it's from somebody that it's for somebody that you have served alongside with, and it is he's a phenomenal man. He's somebody that I really appreciate as well. But Bob Fogel, class of
Oh,
1976. I couldn't say it better myself. Gurtej was a great, impactful member of the board. And I think that sums it up, Gurtej. Just a lot of appreciation. And, he hopes that Etown has future plans with you, and that you have future plans with Etown, I'm sure. So, but I really appreciate a fellow member, a fellow board member alongside you at that time, sharing those comments about you, and I couldn't agree more. So
it's too kind. Bob is an amazing human, an amazing individual. His love of the college far exceeds mine. He teaches me how to show that love and how to give back in ways that I still would love to learn. I thought he was going to heckle me, but
maybe that's to come.
Maybe that, maybe I'll get an email later that he. But that's very sweet. I hope he's doing well in Kansas. It's probably getting cold out there. And Bob, if you're still listening, I'll be out there for some Kansas City barbecue one day.
That's awesome. Yeah. Well put, Gurtej, and I couldn't agree more about Bob. Hope all is well with you. So, but Gurtej, thank you so much for all of your time this evening, all of your effort that you put into this, and just for caring about Etown. I think some really special memories of the two of us, obviously with tennis.
Yeah.
And the long ride down to Hilton Head, with you driving, and me riding in the shotgun position, so to speak, listening to Dave Matthews, and you teaching me about Sikhism. And I will never forget that. Those were some of the most special hours, some of the most special days that I had, not just on that trip, but within our friendship. So really special moments. And yeah, so I also appreciate that you love Etown, and that's something that you and I shared together as well. So thank you so much for your continued service to our alma mater. And so are there any parting words that you have for us at this time?
Boy, no, like I said, it's very much an honor and a privilege to have been asked. Didn't realize we were the first go around with this event, so I certainly wish you and the entire team all the continued success. As alumni, yeah, during Corona, it's been quite difficult to get together, and I'm sure we all missed the amazing Oktoberfest tent that Mark was the one. For those of you who don't know, pitched it many moons ago, and the board of trustees hummed and hawed for maybe about 30-40 seconds, and somebody chimed in and said, "Hey, this is going to be really good." Mark understands the Alumni Society and has a great finger on that pulse. And so it has been an amazing success every year, and certainly looking forward to that next year. No, the love for Etown, it's given me the beginning of my path of education, and what I've become, as hopefully everyone can tell, my absolute passion in life is spine care, and kind of all started at Etown and then has progressed, and what you give, you receive, and so you keep giving back.
Well said. Well said. Thank you so much, my friend.
Thank you, Mark.
This has been great. And to all of our viewers, thank you so much for being here this evening. And to our greater Etown family, remember, we are Blue Jays always.
Always.
Always. Hope you have a great night.